So good evening, everyone. I'm Dr. Matt Rudolfer, Chair of the WPS Continuing Medical Education Committee. I'm pleased to welcome you to the first 2026 edition of our second Wednesday of the month CME event. Tonight, with our distinguished presenter, Dr. William Lawson, we'll be exploring how features of our patients' demographics can play an important role in how medications we prescribe are handled by the body, are tolerated or not, and ultimately, hopefully, do the job for which they are being utilized. We'll have time for questions at the end, and as usual, watch out for an email from our CME director, Kathy Thompson, with instructions on claiming CME credit for this evening's program. Our speaker, Dr. William Lawson, is founder of the Institute for Reducing Disparities, LLC, immediate past president of Senior Psychiatrists Incorporated, professor of psychiatry and behavioral sciences at George Washington University, emeritus professor of psychiatry and associate dean for diversity at the Dell Medical School, University of Texas at Austin, emeritus professor and former chair of psychiatry and behavioral sciences at Howard University School of Medicine, and last but certainly not least, a treasured member of the WPS CME committee. Dr. Lawson received a PhD in psychology from the University of New Hampshire and an MD from the University of Chicago Pritzker School of Medicine before completing residency at Stanford University and a fellowship at the National Institute of Mental Health. He's held multiple faculty positions and has served as past president of the DC chapter of Mental Health America, Black Psychiatrists of America, and of course, the Washington Psychiatric Society. A distinguished life fellow of the American Psychiatric Association, Dr. Lawson's many accolades include the American Psychiatric Foundation Award for Advancing Minority Mental Health, the Gene Spurlock Award, and the Solomon Carter Fuller Award by the APA, the NAMI Exemplary Psychiatrist Award, and the George Winnaker Clinical Research Award from the American Academy of Clinical Psychiatrists. A former editor-in-chief of the Journal of the National Medical Association, Dr. Lawson has over 200 publications, including his newest book entitled African American Health. A longtime scholar in the field of ethnopsychopharmacology, Dr. Lawson's presentation this evening is entitled, Does Race and Ethnicity Matter? Take it away, Bill.
Thank you very much, and I'm just going to go right into it. I'm going to share my screen, and there we go. And comments, just want to note that I don't have any disclosures. That's the advantage of retirement, is that don't worry about that anymore. I will say a few off-label events. And want to note that the objective is going to be to recognize the biological and social determinants in ethnopsychopharmacology, recognize their ethnic differences in pharmacological drug metabolism, recognize that special care must be taken with side effect profiles when different ethnic groups are considered, and to recognize the disparity of minority groups in relationship to access to care, stigma involved in seeking care, and psychopharmacological treatment. I think the key thing is that try to bring in a little science into some psychosocial issues as well as some biological factors in terms of how they intersect. Now, been recognized for a while that the U.S. is has a very diverse population from folks who've been in the continent of North America. We're now bringing it back to a couple of 60,000 years, all the way to multiple groups that have immigrated here. And what we find is that the whole idea about who was the majority group was mostly white Western Europeans, is now becoming relatively minority to the other groups. And I'm going to be focusing heavily on African American non-Hispanic, which has been pretty steady in terms of their percentage of the population. There are several reports that are very interesting. One is the famous mental health report of the Surgeon General, which made several observations that I think for most of us not that surprising. One is that mental disorders are common, they're treatable, but also that not every group gets the benefits. And then the supplemental report showing that there really isn't a substantial difference in terms of the prevalence of mental disorders among all these different groups, but there is a substantial illness burden. And this illness burden is a direct result of the lack of access to a large extent. What we find is that white adults are more likely than Hispanic and Black adults to say that they received mental health care in the past 3 years. Actually, this goes through the past 10 years, past 20 years. This slide, this was in 23, very similar to what we see in 26, unfortunately, very similar to what we would have seen in 2000. And that is when you look at ethnicity, people who are reporting fair or poor mental health status who received mental health services, you find that white Americans, about half of them are able to get it, but Hispanics, African Americans are often less likely. And we also, interestingly, find the same phenomena for Asian. Next one. Next one. I think we went through these. Distribution of population again. And the report. And then the next one. And again, I just want to emphasize again that among adults who report fair or poor mental health status, white adults more likely to have received care and previously, whereas Hispanics, African Americans are less likely. Next one. But on the other hand, when we look at the opinion of people about mental health services, over half of them reported that mental health services were either very helpful or were extremely helpful or very helpful. So people who got services were satisfied. Those who did not get services, of course, we don't know what would have happened. Next one. The reason why treatment is not available for all groups, for African Americans, but also others, is complex. And what we find is that there's that the treatment that's not available includes lack of evidence-based interventions, integrated care, specialized community interventions, and what we'll say a little bit more about is there's less use. Not only is there less use of newer medications, but there's less use of especially antidepressants in general. And what we recently find is that agents such as buprenorphine are less likely to be used by African Americans. And then on top of that, in general, assisted medication therapies for addiction are less common, less available for African Americans. Next one. So what is the basis for us? Some of it is related to individual issues such as stigma and a lot of mistrust, especially after the pandemic exposed a tremendous amount of mistrust that still exists in many communities. But also there are financial insurance barriers. I just went to the store to pick up some medication from my pharmacy, and they said, "Whoa, it's cost $1,000." I said, "What?" So I think a lot of us, unfortunately, because of changes in Affordable Care, are going to find that some healthcare costs we've ignored have shot up. Then there still continues to be absence of culturally competent providers, and I'll say a little bit more about that. Next one. So part of it has to be less likely to do the evidence-based interventions, integrated care, specialized community interventions as well as different types of medication. Next one. Now, what we also have recognized for a long time, but unfortunately, firstly in recent years have ignored, is that all populations, irrespective of racial group, exhibit substantial intra-population variability. And by the way, this is very interesting among Homo sapiens. We just recognize that Homo sapiens, among all many million groups, actually has less diversity than any others several 100,000 years ago, there was a bottleneck. And as a result, some may consider us all clones of each other. But nevertheless, there are different biological and ethnic determinants that are maybe important in terms of medication prescribing and development. Next one. One of the issues that came forth was the development of the drug Vital, which started out as a agent to treat to treat uh, hypertension, congestive heart failure, and was found to be more effective for African Americans. Relative, in fact, it sure almost not much effectiveness at all for non-African Americans. As a result of trials with that agent, the FDA, for the first time, approved the agent based on, for want of a better word, race than any other group. That created a startling debate, discussion, and it exposed, I think, the appreciation that that we still may need to look more closely at folks' racial and ethnic heritage rather than we had in the past, saying that it was really largely irrelevant. Next one. Move on to the next one. There we go. And one of the isoenzymes that's involved in terms of the metabolism of these agents is one is cytochrome 3450, CYP2D6, which has been shown very important in at least 30 psychotropic medications, and which shows racial and ethnic variability. One of the interesting points about this enzyme is that there are individuals who are poor metabolizers who have deficient or inactive alleles, and what will happen is that if they have these alleles, these inactive alleles, drug levels would run higher, and the individual may have more severe adverse side effects. On the other hand, we also recognize that there are some populations that are ultra rapid metabolizers, and as a result, the medication will be seen to be ineffective for these individuals. The problem is not that the medication is ineffective, that they're metabolizing at ultra fast levels. Next one. Next slide. And here's this fairly complex slide. I'll just go through this. If you look at the Caucasian side, moving to the far left, we have functional, we find there's tend to be more likely to have functional alleles. But when you go all the way to the far right, I'm sorry, what you find that where the alleles or have reduced function, you find that African Americans, Africans, and Asians tend to have much more likely to have these reduced function alleles. And translate that, what that means clinically is that the people with the functional alleles will have medications that have the levels, plasma levels that consist of what's in the most research studies. But when you look at African Americans or Asians, what you'll find is that the same clinical dose will be much more effective at lower doses because there's reduced functional layers and plasma levels of whatever medication that's involved will be higher. Next one. So, well, what we find interestingly is that contrary to what we would expect from pharmacotherapy, is many times there's a mismatch of what's happening in terms of medication dosing and prescribing and what should be happening in terms of pharmacokinetics. So what if you go to the bottom part, genotypical differences, what we find is that for African Americans and Asians, there's a shift to the right for the CYP2D6. The result is these individuals will tend to have fewer more slow metabolizers, which means generally higher plasma levels. But on the other hand, what we find in the clinical observation is that, interestingly enough, Asians and Latinos, as you'd expect, end up being on lower doses of antipsychotics, antidepressants. But then, when we look at African Americans, interestingly enough, folks end up on higher doses of medication, contrary to what you would expect from the pharmacokinetics. Next one. So, and what we find in African Americans, we end up with more PRN medication, more medication beyond its prescribed dose, higher doses of psychotropic medications, more different medications, more injectable medications, more depot, and less likely to receive antidepressants. And what we suspect is this much more related that the clinical dosing is not so much a result of individuals in terms of their pharmacokinetics, but how they're perceived in society. So African Americans are often perceived as being potentially more dangerous, more violent, and so forth, and as a result end up in higher doses of medication, which you would not predict from the pharmacokinetics. Next one. And part of it is also confounded by the fact that we just don't have as much knowledge, because African Americans are less likely to be involved in clinical trials of recently approved drugs. It's really a problem in terms of development of Alzheimer's agents, but also psychotropic agents in general. And we're looking at numbers like 5% in pivotal trials. We did a review of the literature, and only 1% of studies in biological psychiatry is ethnicity identified at all. Mm-hmm. Next one. And if you look at genetic studies, we've done a lot of work now at the Human Genome and other projects. But if you look at who's in these projects, well, what you find is that people of European ancestry are grossly overrepresented. Now, we know that the world has a large number of people who are Asian and African ancestry, but they are not in many of the studies and much of what we understand in terms of the human genome. And the reason is they're not included in these genetic studies. Next one. My colleague, Sam Paku, among others, noted very early that lithium is different in African Americans in the sense that there's a greater RBC to plasma ratio. And what we know about lithium is that the RBC to plasma ratio is a good predictor of clinical responsiveness. How much is actually available outside of the cell is very important. And as a result, there's been some work, colleague Tony Strickland, showing that African Americans may have more side effects at the standard plasma levels and probably should be on lower doses. And also may explain why compliance with this agent is lower among African American populations. Colleague Richard Williams did some work, among others, and he developed the idea that this may have been a result of a consequence of the Middle Passage. When the initial slaves were brought into the U.S., there was a very, very, very high rate of death going on the slave ships, and a lot of it had to do, what we found later, with death from folks not getting enough electrolytes. They were hydrated often enough, but they certainly weren't given electrolytes. And as a result, it was that folks that were able to survive and that did make it to the U.S. ultimately tended to have a different RBC, the plasma response in terms of lithium. Next one. On the other hand, there was a study, myself involved, in which we looked at ziprasidone in African American patients with schizophrenia. This is a result of several short-term studies. And consistent. This one is very consistent with several other studies with the newer antipsychotic agents. Next one. And basically what we find is that there isn't that much difference, especially with the newer antipsychotics, in terms of response to these agents. That we really didn't find much difference in terms of African Americans, Asians, anyone else. So it's showing that intentionally or unintentionally, we're moving towards the direction of what seems to be agents that are less affected by the race and ethnicity of these compounds. On the other hand, next one. The story is somewhat more differently when we look at the situation with clozapine. Those of you who are aware of the story, that a lot of us were taught that all antipsychotics were equally effective. Then along came clozapine, which is seen to be much more effective than standard antipsychotic agents. There's been attempts to try to develop other agents that's showing similar efficacy and maybe moving in that direction. But the bottom line was that compared to other first generation antipsychotics, clozapine consistently showed superiority in treatment resistant patients with schizophrenia and bipolar disorder. Next one. However, what we find is that this agent, and by the way, this is another interesting phenomenon, is that it's also one of the few antipsychotic agents that actually has demonstrated efficacy in terms of treating suicidal behavior. So it's good reason why this agent should be considered. But the downside is that, and what kept it from getting approved very early on, is that it caused agranulocytosis in much greater rates than with other antipsychotics. So to get this agent available, we initially had to demonstrate that it was superior because of this potential lethal side effect that occurred in a very significant number of patients. What we find, however, is that this agent, again, this lead that is shown to be more effective in terms of the older agents, is grossly underprescribed among African Americans. And so some of us felt that this leads to disproportionate suffering for health, social, and economic outcomes. The very nice study that was done at the University of North Carolina shown much greater rates of underprescribing of this agent among treated patients. So the question is, why is this agent underprescribed? And what we've, the social and economic factors that's consistent with seeing with other agents, but also African Americans tend to have what we call benign neutropenia. Benign neutropenia, if you think back, the neutropenia, white counts of African Americans on average tend to be lower than other racial and ethnic groups. Next one. Now, the important thing is that this may limit clozapine access because you must have good evidence that white count is not demonstrably lower. Again, this agent thought to cause agranulocytosis, reduction in white count, so you don't want to give it to people who may be already at risk for developing a low white count. Next one. And because of the concern about low white count, the FDA developed what we call the risk evaluation and mitigation strategy, which was that to reduce the risk, people who was to be started on clozapine had to have absolute neutrophil counts that were high. And in fact, the was recommendation that these initially that we check white blood counts on these patients initially weekly, then it moved to monthly, and then it's a little less frequently. But the idea was that you didn't want to start patients on clozapine that had white counts that drifted into what we would consider too low a range. Next one. So the recognition that this reduced the availability among African Americans essentially led to a hue and cry and complaints to the FDA. I was involved with a joint meeting that occurred in November 2024, where we essentially made the case that we need to discontinue this REM requirement because the REM requirement was theoretically maybe protective, that at the same time reduce the likelihood that African Americans would get an agent that was more effective than any other agents. And the FDA eventually went along with it. The REM requirement was removed, and prescribers should still monitor levels according to the frequency described, the prescribed information if they wanted to. This is important for another reason too, and that is when we did the trials, did the findings, noting the white count. When a decision was made to introduce the REMS, clearly they did not take into account these racial and ethnic differences in terms of white blood cell counts that existed in the population. Next one. Now I'm going to shift topics to another agent that I think may have been restricted because of a lack of appreciation of racial and ethnic differences. Now, we recognized recently that there's been a problem in many communities with opioid deaths, partially because of the ready availability of agents such as oxycodone and others. Next one. A lot of it is prescribed. Next slide. A lot of it is unprescribed and have gotten in the streets. Doesn't matter where it came from. There's still what we found was that the opiate overdose death rate shot up in the country when these agents were made readily available. Next one. So overdose deaths became a major problem. Actually, much of a major problem among Caucasians initially, but then the African American community caught up. And they're caused by people who either abused or mixed other substances with it. A lot of these related to people who were substance abusers and who wanted a high or who wanted to deal with the stresses of life, but who overdosed these agents. It's partially related to mental health issues. One of the interesting things is after the pandemic, we had high death rates from suicide. And I've often wondered how many of these overdose rates are really hidden suicides. There's no really good way to tell because people who are successful don't really provide much of a history. But it became important to recognize that we now had a new problem from the pandemic. And not only that, that is that people decide to self-treat some of the anxiety and depression, some of the stresses of life by using drugs of abuse, especially opioid agents. Next one. And it's just showing that during the pandemic, these rates shot up. It was also helped along by the development of synthetic opioids that really shot the rates up. And what this our point about these slides is that these high rates were seen. It didn't seem to matter if these were people that were getting prescribed opiates or get them on the street. Rates went up for all. Didn't matter. Next one. So, and I just want to add to another point, and that is that in terms of dealing with especially ethnic minorities, racial and ethnic minorities, these kinds of mental health issues, stress that occurred, the pandemic and others, folks are much more likely to be incarcerated rather than treated. And just a reminder that jails and prisons hold more people with mental illness and co-occurring substance use disorders than most inpatient psychiatric facilities. And also war on drugs was heavily focused on incarceration and punishment rather than treatment. Next one. So again, how to deal with it? Well, of course, there's incarceration, which is not a treatment, but there's also, we now have medications that are important elements in terms of drug abuse treatment. Methadone, one of the first ones, very effective in terms of reducing criminality and death rate from opioid overdose. Naltrexone, which is not itself an opiate, but an direct opiate blocker, which reduce tendency of people to use these drugs. And more recently, buprenorphine, which is a partial agonist. Next one. And when these agents are used, what we find is drug use goes down, crime goes down, and employment goes up. It's well demonstrated. We're involved in a large study showing this phenomenon. Next one. And they're cost effective. Again, just to show what, at least to this audience, is probably not surprised when you put money into treatment rather than into imprisonment. It's much more cost effective in terms of society. Just want to keep this in mind as we move forward. Next one. And also, the other interesting phenomena is that when you look at the prevalence of substance use disorders by race and ethnicity, what we find is that, surprise, surprise, those that need treatment, you don't find much difference in terms by race. There's a general idea that 1/3 of African Americans have a lot more substance abuse and need a lot more treatment and so forth. Doesn't show up in the literature. Doesn't show up in the literature. Next one. What we do find, however, when you look at treatment admissions, people who have access to treatment, African American, non-white, Hispanics, even Native Americans, we just started huge side the previous one on how Native Americans have high rates of needing treatment. When you look at actual treatment admissions, you find that the numbers are very, very different. That is that African Americans, Native Americans, Hispanics are less likely to get into treatment programs. Next one. So it comes in with buprenorphine therapy. How does this tie it in? Well, again, this product was developed. I mean, the problem with methadone that made it less, people were less willing to accept this because it itself leads to addiction. It's primarily an opiate agonist. Buprenorphine is a partial agonist. That is, that sure, it produces some elements of addiction, but at the same time, it also blocks the more severe tendency of addictive behavior. Next one. So the properties are, if you can hit the slide button, it's a synthetic opioid, but it's a partial agonist. Next. It's less reinforcing than a full agonist and more acceptable to patients than a full antagonist. People can go back to work, they can function in society. I treated several patients who were actually religious leaders who were able to function, and several DC legislators. Next one. And it's much, much easier to withdraw. So, and you have an overdose ceiling effect. It's a lot safer. So we have an agent that it's a partial agonist, and because it's partial, it can block the use of the more toxic opioid agents, and at the same time prevents or reduce the likelihood that people will turn to criminal behavior and others. Next one. So again, it's like for agonists, it increases the activity at lower doses. Next one. Next one. So again, what we find is that's very effective agent for people quitting opiate abuse. In our study, that was very effective in terms of the local DC population replicated around the country and around the world and other countries as well. So we have what looks like the perfect agent in terms of addressing medically on the problem of opioid use. Next one. But guess what? Surprise, surprise, surprise. Buprenorphine less available for African Americans, less likely to be on it. Why and why is it? Well, again, the usual healthcare inequalities that we talked about earlier, less likely to be on not only medication, but new effective medications. An issue about provider shortages. What we find is that private, Dr. Chapman, a local physician who has a large number of these patients, has written extensively about that there's a lot of resistance in the community among insurers, among providers in terms of using this agent. And as a result, especially with the philosophy that the best treatment for opioid use is some sort of incarceration or criminality, these agents simply aren't being made available. Next one. Yes, in addition, there's some studies showing that consistently white patients end up on higher doses of the medication, which means that they can get better outcome results. What we've found is that not only they end up in high doses, they're more likely to get it. African American patients often do not get it, and as a result, end up having higher rates in terms of opiate death rates, even though this agent is available. Next one. So we got these kinds of mental health service gaps. We got barriers towards access, and we talked about economic disparities and stigmas. We got low self-service utilization. The mental health service rates utilization are low among African Americans due to cultural content providers, maybe factor, economic factors, as well as the perception that African Americans should not be made have access to mental health treatment or substance abuse treatment, but are more likely to end up in the criminal justice system. So we got to have more targeted outreach, got to look at policy and community education. Next one. Now this one is interesting, and there's the discussion about why should we talk about inclusion and recruiting more people from different racial and ethnic groups to be in terms of education and so forth. And what we find is that African Americans are much more likely to be treated by African Americans, and Hispanics are more likely to be treated by Hispanics. Next one. And on top of that, there's some evidence that race matching improves outcomes for African American providers. That's a little, I'm just putting a little caveat. We did a VA study, found that we had the African American providers tended to have better outcomes in terms of white patients as well as African American patients. It may be a selection factor because you're obviously you have a restricted system. The African American providers probably had to be better. Continue, next one. And given that we're now again living in an environment which we're taught that diversity is relevant, that we really don't need to focus on getting different ethnic groups and racial groups in terms of positions. And yet, and if you look at what this means, for the past 120 years, we found, for instance, that African Americans who are physicians, we got pretty much the same rate as we've had since the 1940s, um, which means that if, in fact, your provider ethnicity is a factor in your care, we have done very little in terms of increasing the likelihood that people who are of African American descent will get a provider who is like them. Next one. I just want to bring into attention the work that the National Medical Association is going. Just a little history. The National Medical Association was formed because African American physicians could not join the American Medical Association. The only way you can become a member of the American Medical Association is that you're recognized by someone who was a member at that time. And what that also meant is that in order to have hospital privileges, you had to be a member of the American Medical Association. So African American physicians were pretty much excluded from many hospitals. National Medical Association took a strong stance against that, and it's since then has been a real advocate in terms of programs such as the Affordable Care Act and so forth. The organization has recently been promoting what we call Project Impact, which is trying to increase more African American patients and providers in terms of participating in clinical trials and rectify the underrepresentation in these trials. Next one. So what the challenge for many of us then is we need to do more to work on treatment adherence, getting people to recognize that medications appropriately dosed can be effective and also improve health care outcomes. We also need to deal with health stereotypes in terms of providing positive depictions of diverse individuals, managing health aimed to challenge stereotypes and encourage healthy behaviors. And we got to improve. We think that healthcare inclusivity is a good thing. Unfortunately, that's inconsistent with some of the latest political views, but we suggest that there's evidence that shows that inclusive health visuals and messaging and increasing participation from providers and patients pay dividends in the long run. Next one. So we need to do more research and about psychiatric disorders and impulsivity outside of the mental health system, especially for ethnic minorities. Another whole discussion about, and the point that I made earlier is that many people who have mental disorders do not end up in systems that provide mental health treatment. We need to do more research in personalized medicine, recognize strong individual differences. Interestingly, I was commissioned to do a study with the FDA to see how much representation is there in clinical trials, and found that African Americans are overrepresented in trials of schizophrenia, but underrepresented in trials of Alzheimer's, depression, and anxiety. And unfortunately, I think reflects some stereotypical views. One is the African Americans are grossly overdiagnosed with schizophrenia, but also are presumed not to become depressed or anxious. So again, the more studies need to be done to be able to have be more inclusive across different illness disorders. Next one. just want to encourage my book, the African American Health, and I'm recently just finished another book looking at the consequences of COVID on the African American community, which help expose many of these disparities that still exist. Next one. This is you'll find in this book, myself and Dr. Prim, who went back and documented some of the disparities that still exist in psychopharmacology. Next one. And there's my book, Cross-Cultural Psychiatry, older book, but it talks about some of the studies that we've discussed. And there's a more recent book by Donna Norris and Dr. Prim, which again talks about a number of contemporary issues in terms of not only psychiatric care, but contemporary challenges of being an African American in America. Now, end the session and turn it over to Dr. Rudolph for his comments and thoughts.
Thank you, Bill. That was terrific and very enlightening. So I just want to take a moment to revisit a long ago small study that underscores one of the key messages of the evening. Can I have the first slide, please, Kathy? Thank you. So deep in the archives of the British Journal of Clinical Pharmacology, this cross-ethnic study of tricyclic antidepressant metabolism took advantage of the fact that there were a number of visiting Chinese scientists working at the NIH at the time. Each of the 14 Chinese and 16 Caucasian healthy volunteers took a single 100 milligram oral dose of desipramine, with serial blood and urine measures for desipramine and its 2-hydroxy active metabolite collected over the next 5 days. Next slide, please. Looking at the total clearance of desipramine from plasma, the main finding seen in the upper box in the middle pair of numbers was that most subjects in both groups were similar in the intermediate range. A minority, about 25 to 30% of each ethnic group, had extreme values of tricyclic clearance in opposite directions, as Dr. Lawson showed earlier. A quarter of the Caucasian volunteers showed rapid clearance, suggesting they might require higher than usual daily doses to achieve therapeutic levels. At the other extreme, nearly 30% of the Chinese participants were slow metabolizers, suggesting that usual daily doses would likely prove excessive and difficult to tolerate. These would be the kinds of individuals who could achieve adequate drug levels at what might appear to be subtherapeutic daily doses. All of which is to underscore the point that race and ethnicity are important parameters in understanding how to best prescribe medications, but do not tell the whole story. While we should be aware of the greater likelihood of particular responses or activity levels of specific metabolic processes observed in specific racial and ethnic groups, in many cases, these are averages and may not apply to every individual. So, as we saw in a recent slide of Dr. Lawson, personalizing treatment is always the goal. And now we have time for a couple of questions.
Hi, can you hear me?
Yes.
Great. Yeah, Dr. Perman here. Thank you, Dr. Lawson, for that and for this discussion. Just your last comment, Dr. Rudolpher, that personalizing treatment is always the goal. This applies to psychotherapy as well as to psychopharmacology and pharmacology, in that we're always trying to, I am, and I think we should all be trying to get an idea of how this patient in front of us is different from the other billions of patients on the planet here, and key into their specificity and individuality. So I think what you said applies across the board. A lot of what Dr. Lawson had to say was certainly disheartening in terms of African Americans getting the short end of the stick, and there's still a lot of ground yet that needs to be covered and changed. And individually, we all want to do the best we can to put aside prejudices that we all have uh, as we work with our patients and treat our patients, you know, whoever they are, wherever they come from. Thank you. Yeah.
Thank you for very thoughtful comments.
Mhm.
Dr. Lawson, have there been recent studies on the long-acting injectable antipsychotics in terms of ethnic differences?
There's been some studies in terms of, obviously you referred to one of my earlier papers a couple of years ago, but there is studies in terms of availability, not necessarily in terms of treatment and efficacy. But what we find is that there are real differences in terms of people having access to these long-acting agents. And what we find is that initially, in the early days, African Americans are often more likely to be put on them. More recently, we're finding that they're less likely to get the newer ones that tend to have fewer side effects and hopefully better response rates. So there's been a couple of them, and I think that two issues. One is that these agents probably aren't used as often as they should be, and especially with the new ones that have fewer side effects. Long struggle with the District of Columbia, who
Oh,
just has been very reluctant to pay for these agents. Part of it is stated costs. These agents, if you look at their you look like they more costly. But if you spread it over time and try to, then you find that the costs are really pretty low. And there was a famous study done when it comes to Janssen, which found that when you use it to people who come out the correctional system, you actually reduce the rate in which people are reincarcerated.
mm.
Uh, so there are some real advantages of these, and then again, I think what we often do not do enough of is recognize that outside of the mental health system, we are developing technologies that could have some broad social concerns. Um, and again, I'll say my usual political statement that I do not think that drug abuse is a particularly treated effectively when you're just going around blowing up boats in other countries.
Hey, Bill, it's Ray Patterson, and you just touched on where I've spent most of my professional life behind the walls in corrections. And as it turns out, over time, uh, there have been more efforts, I should say, and I'm hoping that they don't go away under the current circumstances we live in, where there are monitors like me who go into jails and prisons and see what the mental health systems are like and what's going on. And medication assisted treatment, MAT, is now something that many systems are embracing because they recognize the recidivism rate of getting someone in a jail, releasing them at 12:01 a.m. because the jail is overcrowded. And
Right.
what's open at 12:01 a.m.? The corner, the liquor store, right? Not the clinic. So
Right.
I really wish there was a way we could bring you into the research area, but within corrections, it is so hard to get anything on a research protocol because of all of the other interferences. But there is at least, or there was, I should say, some glimmer of hope and light. But I'm not sure how long that's going to be sustained at this point.
Well, to me, the sad part is a lot of what I said about 10 years ago, and not much has changed. Um, I was getting ready to throw away my slides and said, oh, wait a minute, go back and use them again. Because many of these issues, unfortunately, even though people like you and others and Dr. Rodolfo have been making these points, somehow it hadn't had people seem to have suffered amnesia in terms of some of the findings and some of the observations that is strongly supported by factual information.
great presentation, Dr. Lawson. I just wanted to say that. I appreciate you inviting me. Um, Hello to everyone. I've been working with, I've had the pleasure of working with Dr. Lawson for, I'd say a few months now. And my background is Morehouse College. I went to Harvard for law school. And I've often told Dr. Lawson in these medical groups, there is so much information that's being exchanged that's just not available to the wider public. I mean, it's so much, it's so rich that I feel as though so many more people need to hear this. So I'm just honored to be here. I appreciate you, Dr. Lawson, for the presentation. And it just occurred to me as you were speaking, what makes medical professionals different is data, because a lot of us have been saying this, even on the justice side, on the lawyer side, but you have data and people trust, the public trusts that physicians and medical professionals know what they're talking about. When you put those two together, it's just a different story. So I appreciate it. Thank you.
And thank you.
This is Dr. Perman. I want to make an additional comment.
Please.
Dr. Lawson is on the editorial board of Capital Psychiatry. Okay. Capital Psychiatry is published 3 times a year now. There's an issue, the January 2026 issue is going to be coming out in a few days, and it'll be accessible through the WPS website. It's a beautiful issue. Beautiful photographs. There's poetry in it. There's a fabulous letter from Robert Post about the underutilization of lithium. Okay, today, and there's an article by a 12th grader, on infant and maternal health and how it's affected by cannabis. And this is a well-researched and referenced article. So when you see the next issue of Capital Psychiatry on the WPS website, and we'll let you know, we'll be out there in a few days, take a look at it, look through it. And I would like each of you to send me an article to go into a future issue of Capital Psychiatry. Dr. Patterson, the other day I was working out in the gym. That's when I often listen to my WPS podcasts now, because I'm going to be interviewed in a couple of weeks myself. So I've been listening to these previous interviews, and I listened to yours intently, and it was wonderful. And man, a 2,000 word, couple pages of anything from you about your career, the work you've done that we can put in Capital Psychiatry would be fantastic. Todd Cox, you do so much for the WPS. You have for a long time. All of you have. I don't even have to say Dr. Dunlap's name because she's been such a stalwart in so many areas. I listened to your podcast as well, Dr. Dunlap. So, Dr. Rudifer, I'm sure you have things you could say. Dr. Thompson as well, and Dr. Allen, I see you there. Anyway, yeah, consider sending me something you'd like to see published in Capital Psychiatry, and I'd welcome it from all of you for the next issue that'll be coming out in May 2026. Thank you for letting me say that. Thank you.
Okay, thank you, Dr. Perman.
Yeah.
And, my thanks to everyone for attending this evening. We're going to have to call it a night, and we appreciate everybody coming and your attention and your involvement. And keep your eye on the WPS website, because it's full of all sorts of useful information, as you've just been hearing. And in particular, of course, you know what's going to happen the second Wednesday of February. Be right back here for our next CME event, and watch out for a podcast in between. So on that note, thank you and good night.